You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 10th, 2025. This week, alcohol and health, GLP-1 trial representativeness, diagnosing coronary disease, changing stroke rates in patients with AFib, and blanking periods after AF ablation. While we were on holiday, the U.S. Surgeon General made news by warning about the risks of alcohol consumption. The specifics of the note was a direct, quote, direct link between alcohol and increased cancer risk. Here is a quote, alcohol consumption is the third leading preventable cause of cancer in the United States after tobacco and obesity, increasing risk for at least 7 types of cancer. While scientific evidence for this connection has been growing over the past 4 decades, less than half of Americans recognize it as a risk factor for cancer. For breast cancer specifically, 16.4% of total breast cancer cases are attributable to alcohol consumption. Well, after this, a robust discussion then occurred online, specifically on X. Economist and professional explainer Emily Oster tried to sort it out in 1,200 words. Her post and others went to a big Lancet meta-analysis published in 2018. The title of this was Alcohol Use and Burden for 195 Countries and Territories, 1990 to 2016, a systematic analysis for the Global Burden of Disease Study 2016. I cite this paper because it is a classic example wherein combining hundreds of biased studies do not remove any bias. The authors attempt to describe the PAR, population attributable risk of alcohol. In other words, what would be the effect on mortality if alcohol was removed from the population? Their methods were quite complex. Nearly 700 data sources of individual and population level alcohol consumption, plus nearly 600 observational studies were meta-analyzed. The authors then, of course, it simply made correlations between alcohol intake or non-intake and 23 specific health outcomes. And the main thing to say about this paper, and the main thing that impressed journalists, was the graphs. Gosh, did the authors make these impressive-looking, colorful graphs. Figure 4, for instance, plots standard drinks per day on the x-axis and relative risk on the y-axis, and each observational study is a point. And, of course, they then draw a correlation line, but gosh, it just looks like noise in this line through all these points of noise. The authors even list their limitations, which are numerous. For instance, they only looked at a 1-year time course, and of course, people change their alcohol intake patterns. And then people estimate their own use of alcohol, and any doctor knows this is ridiculous. People differ in their other characteristics that associate with drinking, and no amount of adjustment can fix these confounding factors. And of course, the notion of combining all of these bias studies do not remove the bias. I mean, you could combine 1,000 observational studies, and it doesn't matter. In fact, this is perhaps the most important lesson I have learned about observational studies, and that is the number of individuals does not fix a systemic bias. Unlike RCTs, where large number of events helps reduce uncertainty, in a biased observational study, big numbers does nothing to remove a systemic bias. So as far as alcohol and health go, observational studies can't really sort out these general health correlations. We can probably say 2 easy things, right? Don't start drinking alcohol for health, as this French paradox is also an exercise in confounding and bias. And the second thing we could say is avoid doses of alcohol that lead to drunkenness. That said, I don't agree with the Surgeon General's warning because the observational studies are certainly not definitive enough for general health warnings. However, one thing we can say that we do have good data for is alcohol and AFib. Here, Bradford Hill would be happy because we have at least 3 lines of data supporting a causal role of alcohol in AF. We have, number 1, population-level data that shows strong associations between alcohol intake and AF incidence. We have mechanistic data from the UCSF group showing that alcohol has pro-arrhythmic effects in the atrium, so biologic plausibility. And we have Alex Voskobonic's RCT showing that patients randomized to alcohol abstinence had less AFib than those who did not abstain. And that RCT is published in the New England Journal, and I'll link to it, of course. So when patients have AF, I tell them about the data on alcohol. I state that I'm not a preacher, just a teacher and evidence-based advisor. I think the data on alcohol and AF is exemplary and patients ought to know about it and make their own decisions. All right, next topic is GLP-1s for obesity. Trial data versus real world. JAMA Internal Medicine has a neat research letters from Drs. Bissett and Anderson from the University of Pittsburgh. Their question was how generalizable were the clinical trials of GLP-1 drugs when used for weight loss in non-diabetic patients? I like the concept here because applying clinical trials is one of the toughest jobs for the modern clinician. In fact, I find the misapplication of trial data to patients not in trials to be one of the most common mistakes in evidence-based medicine. It turns out that the weight loss trials of GLP-1s had numerous exclusion criteria, such as people with chronic medical and psychiatric conditions. So the authors took a representative sample from an NHANES survey, about 9,000 patients with obesity. They then applied inclusion-exclusion criteria from the trials, and for each medicine they calculated the proportion of individuals meeting the FDA label indication who also met trial exclusion criteria. Of the approximately 9,000 non-diabetic patients with obesity in their sample, about 90% met FDA label criteria. But of these eligible, quote, eligible patients, approximately 1 in 3 patients also met exclusion criteria. The proportion meeting exclusion criteria were higher in adults older than 60 years. So major depressive disorder, malignancy, liver disease, and uncontrolled hypertension were the most common exclusion criteria. So my comments. I cover this paper for 2 reasons. One is the specific nature of GLP-1 prescribing, which many of us will be doing soon because obesity surely is or will become a cardiac disease. It's only a matter of time before cardiologists are prescribing GLP-1s. But the main reason I cover this paper is that trial generalizability is a core concept in translating evidence. It's important to think not only about who was excluded from the trials, but also who was included. A couple examples. Okay, we're frequently asked to consider ICD implants in patients who have low EF and heart failure, but also have advanced kidney disease. But advanced severe kidney disease was an exclusion criteria from the clinical trials. What's more, we now have subgroup analyses that find that any degree of chronic kidney disease associates with no ICD benefit. Now, this is likely due to competing risks and increase in treatment-related harm. Therefore, I think it is a mistake to apply trial-level evidence for ICD benefit, say low ejection fraction, to patients who have advanced chronic kidney disease. But it is also true that not all trial exclusion criteria are created equally. For instance, also in the ICD trials, patients were excluded on the basis of timing, say 90 days from revascularization or 40 days post-MI. However, we now have at least some evidence that some patients with heart failure and low EF implanted within this time frame can still benefit from the ICD. The HRS and ACC and AHA have published a document outlining ICD implantation in patients not well represented in clinical trials. For instance, consider this, a patient who is previously qualified for an ICD based on a low EF, who then gets a PCI of a distal circumflex, which will not change the overall EF or risk of sudden cardiac death. This patient technically meets exclusion criteria, but likely will stand to benefit from the ICD. Now, left atrial appendage occlusion is another classic example. The most common indication for percutaneous left atrial appendage occlusion right now are for patients who have a contraindication to taking oral anticoagulation. But these patients were excluded from the seminal trials. To me, this is a mind-boggling thing because the seminal trials were hardly favorable, and now hundreds of thousands of patients receive this device in the absence of RCT evidence. In fact, almost every patient who receives a left atrial appendage occlusion device has met exclusion criteria from the seminal trials. The medical community has embraced the procedure for patients who were specifically excluded from these seminal trials. So the GLP-1 paper describes large numbers of patients with exclusion criteria from the clinical trials, and the authors write, quote, "Until there is evidence from high-quality post-marketing studies, the FDA should consider updating labeling to advise caution on generalizing the safety and effectiveness of GLP-1s to populations excluded from pivotal trials." Now, I hope my examples with the ICDs and the appendage occlusion show how tricky that statement is, because on the one hand, it is true that patients with exclusion criteria from clinical trials may not benefit from the therapy. But on the other hand, having an exclusion criteria does not necessarily equate to no benefit. In the case of the GLP-1s, I think it's pretty obvious that payers will find a reason to not pay for these drugs because they're so expensive, so they'll likely not allow payment for patients with exclusion criteria. But clinicians, and medically speaking, I think have a tougher call. And of course, this is where clinical judgment comes in. And thank goodness there is still a role for judgment. And I don't know the right answer with the GLP-1s, but the message, I think, is to look both at exclusion criteria and look at Table 1, patient characteristics, when you're translating evidence. Okay, next topic is stress testing and coronary artery disease severity. The ischemia trial authors have published an interesting study that related severity of ischemia and coronary artery anatomy. Now, this is a bit of a throwback study from the 1990s when I was training in Indiana, when we learned the following rule of thumb back then. When a patient had a positive stress test for ischemia, back then it was usually just a stress ECG, the cath would likely show some coronary disease, but there was a small chance of severe left main or three-vessel disease and a similarly small chance of normal coronaries. In other words, the correlation was real, but not super strong. I seem to remember it this way: 10% left main, 80% just regular coronary disease, and 10% normal. Indeed, some things in cardiology don't change. The journal Circ Interventions has published this observational analysis from the ischemia trial. Recall that ischemia was a huge RCT testing an early invasive versus conservative medical therapy approach to patients who had positive stress tests. Now, moderate to severe ischemia, that's how it got into the ischemia trial. The kind of patient that in our shop go directly from the stress lab to the cath lab. Well, in ischemia, after 3+ years, there was no significant difference in MACE with the two strategies, despite the fact that slightly more than 2/3 of patients in the conservative arm never got a coronary angiogram. Imagine, no cath after finding moderate to severe ischemia on a stress test. It's heresy. No, just kidding. It's not heresy. It's actually evidence. But the one monster caveat in ischemia was that patients had a blinded CCTA so that those with left main disease or no coronary disease were not randomized. Now, I call this a monster caveat because in real life, the thing you worry about with an ischemic stress test is exactly missing a left main. Because if that happens, you're going to find yourself in litigation and it's going to be terrible. Now, the substudy of note in Circ Intervention involved about 3,600 patients in the trial who had interpretable stress tests and CCTA. And the results were similar to what they were in the 1990s. Ischemia severity was correlated with coronary disease extent, but the correlation was weak. The correlation coefficient was only 0.27 overall. Slightly better with nuclear, the R-squared was 0.4, but it was pretty terrible with stress echo and plain stress tests, 0.15 and 0.18 respectively. Even the extent of scar on nuclear imaging had a weak correlation with the extent of CAD. I would also note that this is probably the best case scenario with correlations because, it's in the ischemia trial and these are motivated, high-quality centers that are in the trial. My comments. Now, you might wonder why I mention a study that confirms findings from 40 years ago. I mention it because A, it's good to confirm lessons because lessons don't always stay the same, right? Beta blockers after MI, ICDs and non-ischemic cardiomyopathy, for instance, have changed. The second reason I comment on this paper is that proponents of CCTA use it to favor anatomic imaging over functional testing for the diagnosis of CAD. And I think they have a point because in both ischemia and courage trials, it was anatomic severity, not the degree of ischemia, that associates with the risk of death or MI. Though, to be fair, both trials enrolled only patients with ischemia on stress testing, so there may be a bit of collider bias. So once again, I struggle with the issue of diagnosing coronary disease with either CCTA or functional stress testing. The CCTA, is it the test itself or its dodgy interpretation? In my area where I see in the U.S., I love functional stress testing because it is less likely to lead to downstream testing. And indeed, this is something that our JAMA internal medicine meta-analysis of RCTs of functional stress testing versus CCTA has confirmed. And I'll link to the paper. It's first author Andrew Foy. What is more, there is a decent chance also that if you reproduce symptoms on a treadmill, and it is ischemia, the coronary disease is likely causal, not incidental. But it is also true that if you are after a diagnosis, does the patient have disease or not, and what is the risk? The CCTA is probably better. And if you're in Northern Europe, you're a doctor who hews to the evidence and you treat atherosclerosis medically and with lifestyle. In many parts of the U.S., though, coronary artery disease on a CCTA will lead to a coronary angiogram so as to fix the coronary artery disease. Now, maybe it's my experience as an AFib doc where patients with AFib come in and end up having a heart cath, but I often see incidental coronary disease treated for a problem. In other words, somebody comes in with a problem and they end up with a catheterization or CCTA and the coronary disease is present, but it's incidental. But I have come to accept that the reaction to CCTA is a human problem, not an imaging problem. I think it was Niels Bohr who famously said science progresses one funeral at a time. And I think that's the same with treating stable coronary disease in many areas of the U.S. It will only progress to Northern European standards with funerals. That said, I do want to say one thing about coronary disease. Now, I often visit our cath lab. The EP lab is right next to the cath lab. And when I go into the cath lab, I'm going as a curious journalist. And then I see this nasty RCA or LAD lesion. I mean, subtotal occlusion, big vessel, it looks terrible. And the interventionalist says to me, John, this patient's asymptomatic. When I hear that, an asymptomatic patient with a severe angiogram, my brain plays two movies. One is, it's just an angiogram. Treat it medically. PCI if medical therapy fails. The other movie is, crap, that looks terrible. I would really want to stent. And the reason why I mention this is that despite me reading Courage and Barry 2D and Revised BCIS and ischemia, it's still hard to dissociate this empiricism with the emotion of seeing a really gnarly angiogram. The next topic is changing rates of stroke and atrial fibrillation. This is a really important topic. Jackie P. has published this important paper from Finnish authors who describe changing ischemic stroke rates in patients with AF. Now, one of the revelations from the recent subclinical AF studies Artesia and NOAA were the extremely low rates of ischemic stroke, approximately 1% per year. Now, this low rate, despite high CHAS-VAS scores, was the likely reason that the DOAC drugs failed to provide a net benefit over either placebo or aspirin. Now, low stroke rates in subclinical AF were explained by saying that, subclinical AF is likely different from old-fashioned clinical AF, where if you have clinical AF, you have to have AF symptoms that require an ECG, and the AF has to be recorded on an ECG. But what if the decline in ischemic stroke rates has other causes? Perhaps AFib-related ischemic stroke is just like sudden arrhythmic death and decreasing over time in patients with heart failure. We call these questions temporal trends, and observational registry studies are an excellent way to study these questions. And this particular study was led by Dr. Konsta Teppo, and he led a group of Finnish researchers who used a national registry to study these temporal trends in ischemic strokes in patients who had incident AFib before they had anticoagulation. I'll pause there and think about how important this question is. Every day in AFib clinic, we have to decide if the base rate of ischemic stroke is high enough to warrant oral anticoagulation relative to the bleeding risk. Of course, we have these overly simplistic formulas from the CHADS-VAS score and now the CHADS-VAS score, such that a score of 2 equals 2.2% yearly risk and 3 is 3.3%. But this is kind of soft. I would encourage everybody to read the Jean Quinn et al. Study in Circulation 2017. I'll link to it, where they showed massive variations in ischemic stroke across cohorts of patients with AFib. To me, the Quinn paper is a game-changing paper because it should infuse us with huge doses of uncertainty about the untreated ischemic stroke risk in AFib. Now, I gather that the Finnish registry is similar to the Danish registry and allows study of patients with new AF who have yet to receive a prescription for oral anticoagulation. The authors had 3 groups of about 40,000 patients. So one group were patients without anticoagulation from 2007 to 2010, and then similarly 2011 to 2014, and then the same group in 2015 to 2018. So groups in 3-year periods over time. Now, they used a 28-day quarantine period after the initial diagnosis of AFib, and this is used to avoid finding AFib that was associated with other serious illnesses that could impact stroke risk. They then truncated follow-up at 2 years after the incident AFib to avoid finding progression of AFib risk factors. And the follow-up stopped after an incident diagnosis of AFib if the patient died, had a stroke, or initiated oral anticoagulation, as they were interested in the untreated ischemic stroke risk. The main findings looking at the 3 groups over time: number 1, age and risk factors increased, but overall ischemic stroke rates decreased by 25% from the first 3-year period to this third 3-year period. This was driven by a 32% decrease in ischemic stroke in women versus only a 7% decrease in men. And when looking at ischemic stroke rates at various CHADS-VA levels, the rates of score of CHADS-VA of 1 risk factor, remained low and did not change. Most of the decrease in ischemic stroke occurred in patients with higher CHADS-VA levels. For instance, in patients with scores of 3, the overall ischemic stroke rate decreased by 26%. This was driven by a 39% decrease in ischemic stroke in women, whereas in men, no change in stroke rates were observed over time. When they looked at age, most of the ischemic stroke events occurred in older patients, and in those older than 80 years, they saw a 29% decrease in ischemic stroke, which was, again, more pronounced in women, 33% fewer versus men, a 15% decrease. My comments: this is a super nice study. First, temporal trends is a great use of observational studies. National registries are indeed national treasures because they allow you to look at temporal trends. Second, the knowledge of the baseline risk is at the core of medical decision-making. I mean, we don't use anticoagulants in patients without risk factors, not because their stroke risk is 0, but because the stroke rate is so low that any absolute risk reduction, which would be tiny, would be outweighed by the disutility of taking the pill or an increase in bleeding. It's the same concept in ICD decisions, right? We require a low EF for ICD implantation because patients who have better EFs have lower base rates of VF. The ICD still works in patients with good EFs, but the absolute risk reduction is so small, it's outweighed by the ICD harms. Now, right now in AF care, I think we delude ourselves into thinking we know the base rate of ischemic stroke in patients with AF. This Finnish study shows that the base rate of ischemic stroke is falling, despite an aging cohort who has more risk factors. What's more, in this study, patients with the highest stroke rates had the most temporal decrease in ischemic stroke incidence. This data doesn't tell us when to treat and when not to treat. for that is an individual decision based on a mixture of evidence, judgment, and patient values. But I think this data does help explain why ischemic stroke rates were so low in Artesia and NOAA. Perhaps it is simply that AFib is a less risky condition than it was 20 years ago. Whether this is due to better ways to detect AFib, where we are diagnosing it in its earlier phases, or some other factor, I don't think it really matters. What matters is that there's growing evidence that suggests ischemic stroke rates in AFib are falling. And that's important to know. It should make us more humble about base rates of untreated ischemic stroke. And B, it might help push us to consider changing treatment thresholds. And C, it could allay some of our fear when patients decline oral anticoagulation. And this leads me to my final comment, and it's directed at my friends who are left atrial appendage enthusiasts. In this registry, the most recent incidence of ischemic stroke in a CHA2DS2-VA patient, a score of 5, so a lot of risk factors, was 86 per 1,000 patient years. And if you change that to 100 patient years, it's about 8% stroke incidence per year. Now, that seems high, right? But there's a 92% chance that nothing happens. And this is why I have long believed that the proper control arm in a contemporary trial of patients like Averroes-like patients, that is, AF patients who cannot or don't want to take oral anticoagulation, should be left atrial appendage occlusion versus no therapy. Those who get no therapy and no device do have an elevated stroke risk, but they incur no bleeding harm from the drugs or procedures. And given the falling rates of ischemic stroke, the do-nothing risky 2 arm might be a tough comparator. Okay, final topic is a short one. This is patients' lives don't pause for blanking periods. One thing has always bothered me about AF ablation studies is this blanking period after the procedure where inflammation from the ablation can cause AFib. I usually say to patients it's about 4 weeks, but many of the trials use 3 months. Well, 3 months is quite a long time if you are a patient having AF. It's also quite a long time if we're only looking at 1-year outcomes, right? That's 1/4 of the whole follow-up period. Blanking periods is a topic of a short paper that I wrote with Dr. Mohamed Rouzier, first author, and Andrew Foy. It's in the American Heart Journal, Cardiology Research and Practice Journal. We offered 4 reasons why AF ablation should count all events and not exclude the 90 days after a procedure. Reason 1, patients with arrhythmia in the blanking period are often symptomatic. Some require cardioversion. If a trial measures mortality, well, then non-lethal things like cardioversion don't matter that much. But AF ablation trials are measuring symptomatic events. So symptomatic events are symptomatic events whenever they occur. Okay, reason 2. Many AF ablation trials now measure AF burden. In Cabana and early AF, these were ablation versus drugs trials. The ablation arm had substantially lower AF burden versus the drug arm. However, since approximately half of ablation patients have some AFib in the blanking period, adding those in would reduce the difference in AF burden. In other words, if you're measuring AF burden as an endpoint, excluding a huge chunk of time in one group biases in favor of ablation. Reason 3. Few other trials in cardiology have blanking periods after procedures. Consider just the ischemia trial, which I've already mentioned. In this trial, all causes of MI were counted, regardless of whether they were directly related to the procedure or not. Had revascularization-related infarctions not been counted, the early invasive arm would have demonstrated a significant reduction in MI. The hazard ratio would have been 0.67. Since all MIs were included in the analysis, ischemia found no significant differences between the 2 treatment arms. Reason 4. The inclusion of a blanking period in an RCT of AF ablation makes it more complex in interpreting the results, and it poses challenges for shared decision-making because patients are concerned about all symptomatic events. All right, it was a short essay, and let me know what you think. I know it's disruptive because we've been using these blanking periods, but when I really sat down and looked at this and wrote with Rouzier and Foy, really made me think that perhaps it's time to reconsider blanking periods. So that's it for this week in cardiology. I'm glad to be back. I had a nice 2-week break. I hope you did too. Remember, If you like this podcast, please take the time to give us a rating, write us a review. Let me know if you disagree with anything. Learn from the comments. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.